Welcome back to my channel, Learn with Professor Janula. If you're new here, don't forget to subscribe and hit the bell icon for notifications. In today's video, we're going to learn about multiple pregnancy. Let's get started. A multiple gestation pregnancy means that a mother is carrying more than one fetus at the same time. This situation is not as rare as we might think, because around 3% of women, or about 3 out of every 100, experience a multiple pregnancy each year. When we look at these pregnancies more closely, we find that most of them involve twins, making twin pregnancies the most common type of multiple gestation. Now let's understand the definition. Multiple pregnancy refers to a condition in which more than one fetus develops at the same time inside the uterus. Depending on the number of fetuses present, it is classified accordingly. When there are 2 fetuses, it is called a twin pregnancy. When there are 3, it is known as triplets. And when 4 fetuses are present, it is termed a quadruplet pregnancy. This classification helps us easily identify and understand the extent of multiple gestation, and also guides proper monitoring and care during pregnancy. Let's talk about the varieties of twins. Twins are mainly classified into 2 types, dizygotic and monozygotic twins. Dizygotic twins, also known as fraternal twins, occur when 2 separate ova are released from the ovaries, and each ovum is fertilized by a different sperm. In this case, each fetus usually has its own placenta and amniotic sac, and the babies may be of the same sex or different sexes, just like any other siblings. On the other hand, monozygotic twins, also called identical twins, result from the fertilization of a single ovum by one sperm. After fertilization, the single fertilized egg later divides into 2 embryos. Because they come from the same ovum, these twins are genetically identical and are always of the same sex. Now let's look at types of monozygotic twins. This explains diamniotic dichorionic twins. In this type, the fertilized egg divides very early, usually within the first 72 hours after fertilization. Because the division happens so early, each twin develops its own placenta and its own amniotic sac. Even though the babies are genetically identical, they grow in separate sacs with separate placentas, which generally reduces complications compared to other types of monozygotic twins. Now let's understand diamniotic monochorionic twins. In this type of monozygotic twin pregnancy, the fertilized egg divides a little later, usually between 4 and 8 days after fertilization. Because of this timing, the twins share a single placenta and a common chorion, but each baby develops in its own separate amniotic sac. These are identical twins, and although having separate amniotic sacs offers some protection, sharing a placenta increases the risk of certain complications, so such pregnancies need closer monitoring. Now let's understand diamniotic monochorionic twins. In this type of monozygotic twin pregnancy, the fertilized egg divides a little later, usually between 4 and 8 days after fertilization. Because of this timing, the twins share a single placenta and a common chorion, but each baby develops in its own separate amniotic sac. These are identical twins, and although having separate amniotic sacs offers some protection, sharing a placenta increases the risk of certain complications, so such pregnancies need closer monitoring. Now let's talk about conjoined twins. This condition occurs when the division of the fertilized egg happens very late, usually after 12 days following fertilization. Because the separation is incomplete, the twins remain physically connected to each other at certain parts of the body. Conjoined twins are always identical twins and share many structures, which makes their care and management very complex. Early diagnosis and careful planning are extremely important in such cases. Now let's discuss the risk factors for twin pregnancy. Certain conditions increase the likelihood of a woman conceiving twins. One important factor is increasing maternal age, especially between 30 and 35 years, as hormonal changes during this period can lead to the release of more than one ovum. Another factor is increasing parity, meaning women who have had many previous pregnancies, particularly more than 5, have a higher chance of twin pregnancy. Nutritional factors also play a role, as well-nourished women may have a greater tendency for multiple ovulation. Infertility treatment, especially assisted reproductive therapies, such as ovulation induction and IVF, significantly increases the chances of twin pregnancies. Lastly, genetic or hereditary factors are important, as a family history of twins can increase the likelihood of having twins. Now let's discuss the symptoms of a multiple pregnancy. In women carrying more than one fetus, the pregnancy-related changes are often more pronounced than in a single pregnancy. They may experience very sore and tender breasts due to higher hormone levels. Excessive hunger or rapid weight gain can be seen early, especially in the first trimester. Mothers may also feel fetal movements occurring in different areas of the abdomen at the same time. Severe morning sickness is common because of increased hormone levels, particularly HCG. On examination, more than one fetal heartbeat may be detected, and the uterus is usually larger than expected for the gestational age. All these symptoms together can raise suspicion of a multiple pregnancy and indicate the need for further evaluation. Now let's understand the abdominal palpation findings in a multiple pregnancy. On examination, the height of the uterus is often more than what we expect for the given gestational age, because more than one fetus is growing inside. The girth of the abdomen is also increased, sometimes measuring more than 100 centimeters. While palpating the abdomen, the examiner may feel too many fetal parts, making it difficult to clearly identify a single back or presentation. In some cases, 2 or more fetal heads can be felt, which strongly suggests the presence of a multiple pregnancy. Now let's discuss auscultation findings in multiple pregnancy. During auscultation of the abdomen, 2 distinct fetal heart sounds can be heard at different locations. An important point to remember is that the heart rates of the 2 fetuses should be different, with a difference of at least 10 beats per minute, to confirm that they are separate fetal heartbeats and not the same sound heard in 2 places. This finding strongly supports the diagnosis of a multiple pregnancy. Now let's discuss the role of ultrasonography in diagnosing multiple pregnancy. Ultrasound is the most reliable and confirmatory method for diagnosis. By around the 8th week of pregnancy, separate fetal bodies can be clearly detected on ultrasound, indicating the presence of more than one fetus. As the pregnancy advances further, by about the 12th week, the individual fetal heads can be distinguished more clearly. Early ultrasound not only confirms multiple pregnancy, but also helps in assessing chorionicity and planning appropriate antenatal care. Now let's discuss the role of X-ray in diagnosing multiple pregnancy. X-ray is usually not the first choice because of radiation exposure, but it may be used when ultrasonography is not available. In such situations, an X-ray can help detect multiple fetal heads and vertebral columns, which confirms the presence of more than one fetus. However, its use is generally limited and avoided whenever safer imaging methods like ultrasound are accessible. Now let's discuss the complications that can occur during pregnancy in women with multiple gestation. Because more than one fetus is growing, the nutritional demand on the mother increases, which often leads to anemia due to increased requirements for iron and folic acid. Severe nausea and vomiting, known as hyperemesis gravidarum, is also more common because of higher hormone levels. Pregnancy-induced hypertension is seen more frequently in multiple pregnancies due to increased placental mass. Polyhydramnios may occur as a result of increased amniotic fluid volume. There is also a higher risk of abortion and preterm labor because the uterus becomes overdistended. Now let's discuss the other complications that may occur during labor in a multiple pregnancy. Because more than one fetus is present, abnormal presentations and positions are common, leading to malpresentation and malposition. Premature rupture of membranes can occur due to overdistension of the uterus. There is also a higher risk of cord prolapse, especially after the delivery of the first twin. Uterine contractions may be ineffective, resulting in dysfunctional uterine action and prolonged labor. In some cases, the second twin may be retained due to changes in position after the first baby is delivered. After delivery, postpartum hemorrhage is a major risk because the overstretched uterus may fail to contract effectively. Now let's understand the concept of locked twins. This is a rare but serious complication that occurs during labor, usually when the first twin is in breech presentation and the second twin is in cephalic presentation. As the first baby is delivered up to the shoulders, the after-coming head of the breech baby becomes stuck and gets locked with the head of the second baby, preventing further progress of labor. This situation leads to obstructed labor and requires immediate obstetric intervention. Management depends on the condition of the fetuses and the clinical situation, and it highlights the importance of skilled intrapartum care and early identification of complications in multiple pregnancies. Now let's understand what decapitation means in an obstetric context. Decapitation refers to the complete separation of the fetal head from the body and is considered a very rare and extreme life-saving procedure. It is performed only in exceptional situations, such as severe obstruction during labor, when delivery is otherwise impossible. This procedure is carried out by an experienced obstetrician with the aim of relieving the obstruction and saving the life of at least one baby, and most importantly, protecting the life of the mother. It highlights the seriousness of certain obstetric emergencies and the need for skilled decision-making in critical situations. Now let's discuss twin-to-twin transfusion syndrome, commonly called TTTS. This is a serious complication seen in identical twin pregnancies, especially when the twins share a single placenta. In this condition, abnormal blood vessel connections in the placenta cause blood to pass unevenly from one twin, known as the donor twin, to the other, called the recipient twin. As a result, the donor twin becomes anemic, smaller in size, and may have restricted growth, while the recipient twin receives excess blood, which can strain its heart. TTTS is a placental problem and requires early detection and close monitoring to improve outcomes for both babies. Now let's discuss the management of multiple pregnancy, starting with prenatal care. Since the mother is supporting more than one fetus, her nutritional needs are higher, so a diet rich in calories and protein is very important. Adequate rest at home is advised to reduce fatigue and the risk of preterm labor. Iron therapy is given in higher doses, usually 60 to 80 milligrams per day, to prevent or treat anemia, which is common in multiple pregnancies. Folic acid supplementation of about 1 milligram per day, along with additional vitamins, is essential to support fetal growth and prevent deficiencies. Regular assessment of the fetuses is also very important to monitor their growth, well-being, and to detect any complications early. Now let's discuss the management during labor, focusing on the first stage. In multiple pregnancy, labor should always be conducted under the supervision of a skilled physician, because complications are more likely to occur. A neonatologist should also be present, as more than one baby may require immediate care after birth. Having an ultrasound machine available in the labor room is very helpful to quickly assess fetal positions and presentations if needed. The mother is usually advised to remain in bed during this stage to reduce the risk of early rupture of membranes and other complications, ensuring safer progress of labor. Now continuing with the management during labor, pain relief is an important part of care, and epidural analgesia is usually preferred because it provides good pain control and allows better management if interventions become necessary. Careful and continuous fetal monitoring should be done to assess the well-being of both babies throughout labor. An intravenous line should be established early, commonly with ringer lactate, so that urgent intravenous therapy can be given if required. blood should be arranged and kept ready in view of the increased risk of hemorrhage. The neonatologist should remain ready throughout labor to provide immediate care to the newborns after delivery. Now let's discuss the delivery of the first baby in a multiple pregnancy. During delivery, a liberal episiotomy is often performed under local infiltration with 1% lignocaine to allow enough space and reduce trauma. If required, forceps delivery may be used to assist the birth of the first baby. It is important to remember that ergometrin should not be given at this stage because the uterus still contains another baby and strong uterine contractions could cause complications. After the baby is born, the umbilical cord is clamped and cut, leaving at least 8 centimeters of cord so it can be used if blood transfusion is needed. The baby is then properly labeled as baby number 1 and handed over to the nurse for immediate care and observation. Now let's talk about the delivery of the second baby, which is a very critical step in multiple pregnancy. After the first baby is delivered, the first priority is to reassess the uterus by abdominal examination to confirm the lie, presentation, and size of the second baby. This assessment helps the obstetrician decide the safest method of delivery. If the second baby is in a longitudinal lie with vertex presentation, the delivery can usually proceed in the same way as a normal vaginal delivery. If the lie is longitudinal but the baby is in breech presentation, then breech extraction is commonly performed to ensure a quick and safe delivery. In cases where the second baby is in a transverse lie, correction is necessary. Initially, an external version is attempted to turn the baby into a longitudinal lie. If this fails, an internal version is carried out, followed by appropriate extraction. Throughout this process, close monitoring and prompt decision-making are essential to prevent fetal distress and maternal complications. Now let's understand external version. External version is a maneuver done to correct an abnormal lie of the fetus, usually a transverse or oblique lie. It is performed by applying gentle pressure over the mother's abdomen using both hands. One hand is used to guide the fetal head, while the other hand guides the breech, slowly rotating the baby so that it comes into a longitudinal lie, preferably with the head down. This procedure is usually done after the delivery of the first twin when there is more space in the uterus, and it helps in achieving a safer vaginal delivery of the second baby. Throughout the procedure, the fetal heart rate must be closely monitored to ensure the baby is tolerating the maneuver well. External version should always be performed by a skilled obstetrician and only when there are no contraindications, as careful handling is essential to avoid complications. All right, let's go through the management of the third stage of labor. After the delivery of both babies, the focus now shifts completely to the mother, because this stage carries a high risk of postpartum hemorrhage, especially in multiple pregnancy. Since the uterus has been overstretched, it may not contract well on its own. To prevent excessive bleeding, 0.2 milligrams methergin is administered intravenously immediately after the delivery of the second baby. This helps the uterus contract firmly and reduces the chances of postpartum hemorrhage. Remember, this drug is not given after the first baby, only after the second one is delivered. Once good uterine contraction is achieved, the placenta is delivered by controlled cord traction, ensuring that it comes out completely and safely. Care is taken to check that no placental fragments are retained, as this can also lead to bleeding. After placental delivery, the mother should be closely monitored for at least 2 hours. During this period, vital signs, uterine tone, and vaginal bleeding are carefully observed so that any complication can be identified and managed early. Finally, since the mother has delivered 2 babies, she will require additional support, both physically and emotionally. Extra help is provided to assist with baby care, feeding, and recovery, ensuring the well-being of both the mother and the newborns. This completes the third stage management in multiple pregnancy. In multiple pregnancy, a caesarean section may be needed in certain situations to ensure the safety of both the mother and the babies. If the pelvis is contracted, there may not be enough space for the babies to pass through the birth canal safely. A previous caesarean section can increase the risk of uterine rupture during labor. So, a repeat caesarean may be advised. When there is cord prolapse of the first baby, the umbilical cord can get compressed, cutting off oxygen supply, and this requires immediate caesarean delivery. Abnormal uterine contractions can interfere with effective labor and fetal well-being, making surgical delivery safer. In the case of conjoined twins, vaginal delivery is usually not possible due to their physical attachment. So caesarean section is the safest mode of delivery. N.P. In difficult cases of multiple pregnancy, one important situation is interlocked twins. This happens when the coming head of the first baby becomes stuck or locked with the forecoming head of the second baby, preventing further progress of labor. This is a rare but serious complication that needs immediate attention. Management is done step by step. First, gentle vaginal manipulation may be attempted to try and separate the locked heads so that delivery can continue safely. If this is not successful, and the situation becomes life-threatening, decapitation of the second baby may be required as a last resort to save the life of the mother and at least one baby. If both fetal heads are blocking each other and neither head is able to engage, this situation is usually discovered unexpectedly during labor. It is then confirmed with the help of ultrasonography. In such cases, vaginal delivery is not possible because the heads are mechanically obstructing each other. The only safe and effective management is delivery by caesarean section, which is performed under general anesthesia to ensure quick and controlled delivery and to protect the safety of both the mother and the babies. In the case of conjoined twins, vaginal delivery is not considered safe because the babies are physically joined, which can lead to serious complications during labor. For this reason, delivery is planned by caesarean section and is done under general anesthesia to allow better control and ensure the safety of the mother and babies. When there are more than 4 fetuses growing in a single uterus, the pregnancy carries a very high risk for both the mother and the babies. To reduce these risks, a procedure called selective reduction may be advised. This is usually done between 9 and 12 weeks of pregnancy, where 1 or more fetuses are reduced by injecting potassium chloride directly into the fetal heart under ultrasound guidance. This helps improve the chances of survival and healthier outcomes for the remaining fetuses. Thank you so much for watching. I hope this session helped you understand the topic clearly and made learning a little easier. If you found this useful, please like the video, share it with your friends, and leave your thoughts or questions in the comments. Don't forget to subscribe and turn on the notification bell so you never miss an update. See you in the next lesson.